We are going to be learning from her. She is going to be, telling us more about this breast cancer. You are welcome to join in on the conversation we have of the breast cancer. So let me allow you to come into the studio and greet the listeners and greet the viewers. Tell them who you are. Tell them where we can find you. I know you are in private in Laszlo, in Centurion, the private hospital. We find you there. I know that you are doing so much. You are also part of the Sussex, which trains the doctors who are gearing up to become specialists. And I want to welcome you. I want to welcome you and into the family of In His Grace and Mercy. And then after introducing yourself, then you just tell us about this breast cancer that you're going to be teaching us today. And I'll be controlling your slides. For those that are on YouTube, those that are on Facebook, they can look at the presentation as it is. But those that are listening on the radio, we will make it so easy that you are able to get the maximum from what we're going to be learning today. This is In His Grace and Mercy. I am Pastor Kekana. I am Dr. Kekana. So we are right into it. Dr. Singh, please introduce yourself to the best of your knowledge so that we don't underplay who you are. We don't underplay what you stand for. In case we didn't introduce you properly, you can just say, hey, listen, you forgot this, doctor, and just add this thing. You be free and relax. I shouldn't make you nervous. We're colleagues here. So over to you, and welcome.
Thank you, David. Thanks, everyone. And really, David, thank you for the invite. It's really such a pleasure to be on this platform and be talking about something that's quite near and dear to our hearts itself, something we work with every day, and something I feel that every woman and man should know about. So yes, I'm Dr. Yonita Singh, and I'm a general surgeon, as you've heard. And yes, I practice at Laszlo Private Hospital in Centurion, which is in Pretoria. So today we're going to be discussing, like I said, a very, very important topic, something that I think everybody needs to know, everybody needs to be aware of, whether it's for you, whether it's for your family members. This is something we need to focus on. So we'll take our time to go through quite important facts. And I hope you stick with us, and I hope you have questions afterwards that we can address. So firstly, breast cancer in South Africa is quite a huge problem. So if we look at the South African statistics, 1 in 33 South African women will be diagnosed with breast cancer in their lifetime. And that's quite a shocking statistic if we compare it to other cancers. When we talk about cancers, we sometimes talk about the big 5 or the famous 5 or the top 5 cancers. If we look at the top 5 that affect women, breast cancer is number 1, followed by cervical cancer, colorectal cancer, uterine cancer, and then lung cancer. So most important, like I said, it's our job and our duty to educate women, to empower them as well as men to know about breast cancer. And in this way, we can lower the risk of getting breast cancer. Or if we cannot do that, we can basically detect breast cancer much earlier with more treatment options and, of course, 100% cure rate. So we're going to be going through quite a few concepts, and basically we'll take you through what's important about breast cancer. So I'd like to start off with certain things such as myths and facts. So a lot of the times patients have misconceptions, things you Google, things you hear, and ideally what I want to start off with is a myth. So let's start with the first one. The first one is, I'm too young to get breast cancer. And really that is incorrect. A lot of the women we see are diagnosed with breast cancer before the age of 40. And in clinical practice, actually these days, we're seeing it earlier and earlier. Patients are actually in their 30s, some even in their 20s. So the whole story of only old people get breast cancer, that is no longer a thing. And that's something we need to take cognizance of and be aware of. The second one, which I think is extremely important, is the fact that people say men cannot get breast cancer. That is extremely untrue, as the statistics here is 1 in 249 men will have a lifetime risk of breast cancer. Again, quite shocking for something that is not common in men. But something that we need to be aware of is that either men have some sort of stigma attached to presenting early. So by the time they do present to us, it's quite in an advanced stage, meaning not even only locally advanced in their breast, but actually it has spread elsewhere already and making it a stage 4 cancer. Or they have presented early, have gone to clinics, have gone to general practitioners, and they themselves thought, okay, breast cancer is not common in men, so they didn't do all the necessary tests. So by the time the patient gets to a specialist surgeon, it's actually too late. So very important for men to be aware of minor breast changes as well. It's the same for women, just the fact that it's actually easier to examine because of the less breast tissue. The other one is that alcohol is not linked to breast cancer. Again, not true. Alcohol use does increase the risk of breast cancer. Another myth is that some people think that only people with a history or a family history of breast cancer will get breast cancer. And that's extremely untrue because actually only 5 to 10% of breast cancers have a genetic predisposition or are hereditary. So very important to not think that if you don't have a family history, you are not inclined to get breast cancer. As you can see, 90% of breast cancer is sporadic. So anybody can get it. Yes, a family history increases your risk, but anyone else is predisposed to breast cancer. The other thing is patients often say, I've never had kids, so I can't get breast cancer. Actually, the opposite is true. A, a woman who has not had a child, a patient we call nulliparous, or a woman who has delayed pregnancy to later ages, usually after the age of 30 or 35, you find that those women actually have an increased risk of breast cancer. So these are certain things that we just need to bear in mind because there are a lot of myths going out there and we need to correct these. We need to make the facts known. If we look at what are risk factors for developing breast cancer, so any cancer has certain risk factors. In other words, things that you have that are making you more likely to develop this cancer. And usually how we divide risk factors is risk factors that you can control and risk factors that you cannot have control over. So let's look at the ones you don't have control over. The first one basically being female. Firstly, like we said, it is more common in females as opposed to males. So that's something you can't do anything about. The other thing is, as you increase your age, it does become more common. So especially above the age of 40. That is ideally when we want to target screening high-risk populations. Your genetics, like we said, 5 to 10% of these patients will have a genetic predisposition. So again, you can't change your genetics, but what you can do is pick up that some of your family members have had certain cancers and try and test for those genes. And therefore, you can do preventative operations, which we'll talk about, to decrease that risk of developing cancer. Other things that you cannot change is if you've had your period early. Early being it started before the age of 12, and now you develop menopause late, late being after the age of 55. What that means is that you've had a longer duration before the age of 12 to after the age of 50, you've had a long exposure to estrogen. And that is a problem because breast cancer is estrogen driven. So that's important. If you've had a period early, you've had a late menopause, you need to do mammograms regularly. Another thing is having previous radiation. So radiation, whether it be neck, chest radiation as a child, or any other time you've been exposed to radiation, those are things that we can't really change. Now we look at the things that we can change. Certain risk factors that we can change is things like exercising, maintaining a healthy weight. Obese individuals have an increased risk of developing breast cancer. Lack of exercise for similar reasons. Things like using a birth control pill or hormone replacement therapy, these are drugs known to have, again, an increased predisposition. It changes your hormones. So later on, when you stop the treatment, your risk actually decreases of developing breast cancer. Things like breastfeeding. Breastfeeding is actually protective against breast cancer. And like we discussed earlier, trying to plan your family and not delaying pregnancy to after the age of 35 is actually a good option. So when we talk about early detection, because that's the main aim of any cancer. We want to pick it up early. When we talk about that specifically for breast cancer, there are 5 main steps that we talk about. The first one is practicing routine self-examinations. And we'll actually go through some of these steps, things that you can use, just some tips and pointers that you can practice at home. The second thing, like we said, is knowing your risks and your family history. So, like I said, if you've known that your family, like mother, sister, daughter, have had breast, ovarian, or even family members with prostate cancer, you may want to think of something like the BRCA gene. The BRCA gene is quite popular, people know about it, the BRCA1 and BRCA2, and these are things that you can go for genetic testing. If you do test positive for the BRCA gene, that just tells you that you have a higher likelihood to develop one of these cancers. And yes, there are preventative options to now decrease your risk if you do test positive. A lot of patients who are BRCA positive opt to have both of their breasts removed, something called risk reducing surgery. In other words, we take both the breasts, remove them. Sometimes after family planning, patients after the age of 40 also opt to remove their ovaries as well as their uterus or womb. So very important to think of these genetic predispositions. And if you feel you have that family history, consult firstly your general practitioner, who will refer you to a genetic counselor, and you can do the necessary genetic testing. In this way, you can reduce your risk with certain measures like we've discussed, surgery, or even certain medications. Visiting your doctor regularly is quite an important step. A lot of the times we only go to our general practitioner or a surgeon if we have a problem. By that time, sometimes it's too late. So what we need to do is to think ahead. Always think after you reach a certain age, go for regular checkups. Let a trained professional examine your breast, examine for all those other cancers like we've discussed. And then, like we said, is know when to get a mammogram. We used to think mammogram is only for old people. That's also not true. You can get a mammogram from the age of 35, where your breasts are actually less dense. But actually, even if you have dense breasts under the age of 35, we do sonas. So it's very important if you have these high risk factors to consider seeing a medical professional, getting examined by this medical professional, and getting referred appropriately and in time. And lastly, we said to follow up after your screening tests. So say you've gone for a mammogram, you've gone for a sauna. What we do on the sauna and mammogram is we grade the breasts. It's something called a BI-RADS system. We basically grade you from being a very low risk or non-worrisome breast pathology to a high risk. If you are high risk, it means you are likely that that mass that you harbor is cancerous. Again, those lumps will be biopsied. And if you're on the lower risk or the lower scale, you'll find that actually you get follow-ups much further away than anyone else. So for example, you won't need a mammogram every year, you might need it 2 yearly or even longer after that. But if you're a higher risk patient, then maybe we actually need to follow you up much closer. So once you commit to screening and getting investigated, you actually need to stick to the follow-up program, because as it's designed, it can actually pick up and detect cancers early. Next, we'll look at when we examine the breasts or when we're thinking about early detection, what are things that you'd find in your breast that would worry you? So now let's look at some pictures, basically, for the people who can see the pictures, of what are things that would worry you or concern you when you examine your breast. If you have a nipple discharge, that is an important one. Nipple discharge, for example, during pregnancy, we know will be normal because there's lactation happening, etc. But when your nipple discharge is isolated to one breast, it's coming out by itself, and it is not a clear fluid. It's bloody or brown or greenish stained discharge. That is pathological. It doesn't mean it's cancerous, but it means it should be worked up. In other words, you need to see a trained professional who's going to refer you for a mammogram, send some of that discharge to the lab, and then see, are there any lumps or calcifications in your breast that need to be biopsied? So that's just a worrisome feature that will warn you that you need to seek help. In general, the lump would be the easier one to pick up clinically. If you find any breast lump, it needs to be investigated. Any breast lump, no matter what age group, it doesn't mean it's cancer, but we need to exclude cancer. Any skin changes in the breast, something that you haven't had before that has all of a sudden appeared. Skin rashes, skin dimpling, skin retraction, anything that looks out of the ordinary compared to the other breast needs to be worked up. The other important one is where breast cancer spreads to. Directly next to the breast is your armpit. So if you feel nodules in your armpit, you need to get that investigated. That can be the first sign sometimes that this is in fact breast cancer. Then we look at the nipple itself. Sometimes the nipple inverts or retracts or has skin changes itself, something that looks like eczema. Sometimes that's misdiagnosed by dermatologists or any other general practitioner as eczema, which can be called Paget's disease. So you need to understand that any change in your breast should be examined by a trained professional and preferably referred to a surgeon. Our next step would be to look at what is a breast self-examination. And basically, the breast self-examination is, as they always say, easy as 1, 2, 3. So breast self-examination, again, like we said, is something you can do at home, but it's not something that is 100% reliable. So again, you should do it, but only to pick up these early signs. But the second you find these signs, you need to see a general practitioner who will then investigate and refer you to the appropriate surgeon. So in general, when you examine your breasts, what are things you need to consider? Ideally, try and do it once a month. Try and do it at the same time of the month, and ideally during ovulation. You should examine in, like we said, 1, 2, and 3. 1, stand in front of the mirror. So you've got 2 breasts. Compare the 2 breasts. Is it asymmetrical? Does one look slightly different? Is the skin looking different? Is the nipple looking different compared to the other side? You'll be able to see that in the mirror. The second one would be examine while you're lying down. When you are lying down, you are then going to use the opposite hand for the opposite breast. Again, flat fingers, and always examine not only the breast, but remember we said the armpit as well. And then thirdly, you could examine while you're in the shower. They recommend sometimes putting some soap on your fingers, making it more slippery, but trying to use flat fingers. Again, examining the breast and examining the armpit. So all of this can help, but like I said, it's not a substitute for seeing a general practitioner and being worked up further. So next we'll have is, now you've picked up that you have a breast lump or something abnormal. What is going to happen when you get to the general practitioner? So when you get there to the general practitioner or the surgeon, we are going to re-examine you. So we are going to do another manual examination. And now we're going to look at this lump and we are going to decide, is this an early breast cancer? Is it a later stage breast cancer? So we use something called the clinical T staging, and that just shows us sort of where in the spectrum are you. Have you presented early? Is it a small lump? Is it already fixed to the skin? Is it spread to the armpit nodes? Where are we in the spectrum? Then we're going to investigate this lump. Like I mentioned, if you're below the age of 35, we're going to do a Sauma because your breasts are quite dense. If you're above the age of 35, we're going to do a mammogram. Under this mammogram or Sauma guidance, we are then going to put in a needle and biopsy this lump. With the biopsy, well, firstly, with the Sauma features, like I mentioned previously, we're going to grade you on that BI-RADS system and see where do you fall. If you are higher in the BI-RADS system, meaning it is a more suspicious looking lump for cancer, definitely we will do a biopsy at the time. When we send the biopsy to the lab, we are trying to see, firstly, is this cancer? Maybe it's not. Maybe it's something else that is benign that we can maybe follow up later on. If it is in fact cancer, we want to see what type of cancer is it. We want to see, is it going to be something that is highly aggressive, that might respond better to chemotherapy, or does it have receptors? We measure hormone receptors, estrogen, like we've mentioned before, and progesterone, as well as something called HER2. This can all influence your future management. In other words, it will tell you this tumor is going to respond well to certain hormonal treatment, or this tumor is not going to respond. So we should rather go more aggressive with chemotherapy. So those are sort of the results we will get from the lab. After we've done the imaging tests, we've done the biopsy, and we've confirmed this is cancer, we now need to see what stage of cancer are you in. In other words, has this cancer spread anywhere else? So has it spread and make this a stage 4 disease where the treatment is entirely different, which we'll look at just now? Or we're going to decide, is this cancer a localized treatment that we can offer you surgery up front, or do we actually need to give you chemotherapy and then surgery later on? So again, staging is quite important. After we have staged you and we've decided, okay, you are now a stage 2 or 3 or 4, we then sit on something called an MDT. Now, this is a multidisciplinary team. All cancer patients that we see get discussed in a multidisciplinary team. Basically, what this means is there will be a surgeon on this team, there will be a radiation oncologist, there will be a medical oncologist, and various other team members that are going to be a part of this treatment process. And what we are trying to do is to facilitate an individualized treatment for the patient. Every patient is treated differently. Every patient has a different cancer which behaves differently and requires different treatment. So let's look at what are some of the treatment options of how we would treat breast cancer. The first one, and the biggest one, of course, for us, would be surgery. Surgery can be divided into multiple different ones, but the two main ones that we do would be breast conserving surgery or mastectomy. Breast conserving surgery is exactly that. We conserve the breast, only remove the lump that is cancerous with a margin around it, and then we need to address those armpit nodes, like we discussed earlier. Then the other option is mastectomy. Mastectomy means removing the entire breast, but again, we always need to address those armpit nodes. So there's various ways to do that, but those are the two broad categories. Are we saving the breast because you've got enough breast tissue and a small tumor, or are we going to remove the entire breast? So those are things we discuss on this MDT. Then we decide, at this point in time, are we going to leave the patient completely, well, remove the breast and leave the chest flat, or are we going to do reconstructive options? And this is something that patients don't often think about. They think, I've had breast cancer, I've removed my breast, this is the end of the road, I've lost my breast. So there are options for reconstruction. And this is generally done with a plastic surgeon. In consultation with them, they sometimes join us in the operation or much later down the line. And what we can do at the time is either we put in something called an expander, as you can see on those pictures, or we can take tissue from another part of your body and create a flap, or later on down the line, we can actually do artificial implants. We can even do nipple tattooing and nipple reconstruction. So removing the breast, it's not the end of the road. There are reconstruction options. So that's just surgery. Next, we can talk about chemotherapy. So chemotherapy can basically be before surgery, that is called neoadjuvant chemotherapy, or after the surgery, that is called adjuvant. So it depends. Like we said, if we're trying to downstage the tumor, it's too big, it's not able to be operated now, we will downstage it with chemotherapy. Then we reassess and see, okay, now the patient is good to go for surgery. Or some patients upfront, early stage breast cancer, we might opt to do the surgery first and later on give them the chemotherapy. But like I said, these are things we make on the team, these decisions. Next would be radiotherapy. So radiation is all about controlling the disease locally. So when we look at that, basically, again, that can be something that's generally given after. For example, if you did breast conservation surgery, those patients will all get radiotherapy. If you had a mastectomy, you might not need radiotherapy. It just depends. Do you have high-risk features in your tumor or in the nodes that we got from your armpit? Then we might consider giving you some radiation therapy. And then lastly is the hormonal and targeted therapy. So the hormonal and targeted, like we said, we get those results from the biopsy to say this tumor will respond well to certain treatments like tamoxifen, or like we said, you test for HER2, that has its own targeted treatment as well. So in essence, breast cancer, it's a multidisciplinary approach. It's not something we decide, we see the patient today, we operate tomorrow. It's not like that. We all discuss, we sit together and we see what is the best treatment for this patient. What can this patient tolerate? And what does this tumor in this patient need? Then we look at, like I said, if the cancer is stage 4 cancer means that the cancer has spread. So where does it commonly spread to? It commonly spreads to the bones, the lung, the liver, and the brain. And generally, once we've labeled the patient as stage 4 cancer, for all intents purposes, it's basically for supportive or palliative treatment. In other words, there's no intent to cure this patient because it has already spread way past the breast and the armpit. Meaning whatever we do now is just to either delay the progression of the disease or to control the patient's symptoms. So we'll give them strong pain medication, refer them to a dietitian to get adequate nutrition. We'll refer them again to a medical oncologist to start the chemotherapy and the hormonal therapy, and later on, plus minus, a radiation oncologist. So you can see there are still options for patients who have stage 4 breast cancer, but the point is it is not curative once it's in the stage. And generally, if the older the patient is, the more frail they are, they actually won't survive much longer. So if we just come to mammography, like we mentioned earlier, you need to have a mammogram, like we said. If you have a family history, you can't wait for the age of 40 or 45. You need to have it much earlier, as soon as you can, generally by the age of 35. In general, the general population with no family history or none of those risk factors that we spoke about, then from the age of 40, you should have a mammogram. Like we said, on the mammogram, we're going to grade you and we're going to tell you, do you need to come back in a year? Do you need to come back in 2 years? Or do you actually not need to follow up anymore? And like we said, if you have those risk factors, you yourself need to book your appointments and stick to that screening program. So in essence, just to end off, what I need to say is that breast cancer awareness is key. As we can see, if you pick up breast cancer in the earliest phase, definitely there's a 100% cure rate, versus if you're picking it up in stage 3 or stage 4, where there are now less treatment options. So ideally, examine your breast, present early to a medical practitioner, let them refer you early to a surgeon, and let us do the best we can for you. Thank you.
Thank you. Thank you so much. So much. We thank you. We appreciate what you have taught. And there are a few questions that we're going to address, though. So thank you very much. Dr. Yunita Singh, she's a surgeon, a specialist surgeon, a very good colleague of mine. You know, in the spaces that we're together, she's a leader, and she's a firm and a very quiet, nice leader, I must say. You know, she doesn't need to be told when to lead and when not to lead, and that those are people that we spend this journey when we specialize together. She is found in Raslo. There's a new private hospital in Centurion around Lodium, and you know, based that site, and people in Krugersdorp and all those people around have an access closer to that hospital. So if you need to consult a surgeon, she's there. And I've left the details there for so long so that you can note the details, so that you can consult. You know, don't be afraid. There are people that have things that they cannot ask us as males. And then I think for women this month, that is why we wanted to allude this. Not that men don't have breast cancer. In men, when we find it like she said, we find it well advanced because people don't think about it. And then the breast cancer in men is actually much more aggressive in most cases. And that's why you find by the time you find a man with breast cancer, you find it to have been metastasized already. It's in many parts, stage 4. You can't do much in terms of surgery, but you can do chemo. I've got a few questions. And like I said, this is In His Grace and Mercy. I am Pastor Kekana. I am Dr. Kekana. We're on Sauma HD Radio. It's www.saumahdradio.co.za. You want to ask us questions, please do that. We are live on YouTube. We are also live on Facebook. You can drop a question. You can also drop us a WhatsApp. On our WhatsApp number, we'll be able to read your question and respond to you. And then the details that are on the screen is for you if you want to talk to the doctor. From here, it's going to be chargeable, but In His Grace and Mercy brings it to you for free for now. The number is 076-386-7025. That's our WhatsApp number for you to have questions. And thank you very much for appreciating that. I have a few questions that I want to address so long. So it's in Japan, you know, so that they can have a look and a closer look at the person who's been presenting, you know, so that if they're being given the doctor they didn't ask for, they can just say no, I've got two questions that they asked So let's go right into it. The first one is this. On the screen, thank you very much, Sisfina, for asking us this question. It's a MK team member. On Thursdays, if I'm not on the stand, she's on the stand. So the question she's asking is that, is there a medical treatment only option? Do we have a medical treatment only option? Is there such?
Yes, so definitely there is a medical treatment only option. Generally, if we're dealing with a younger patient, we wouldn't want to opt for that, because what it means is you're just putting the patient on hormonal therapy and you're going to surveil them and watch and sort of hope for the best.
Yeah.
So ideally, if you're a young, fit patient, it's not something we're going to offer you. But there's definitely a role if the patient is above the age of 70, has an early breast tumor that has not yet spread to the lymph nodes.
Yeah.
In other words, is something we call a T1, so an early tumor, N0, no nodes. Then definitely, and above the age of 70, then we do something called primary hormonal therapy, meaning the treatment for this patient is just hormonal. So we start them on something called an aromatase inhibitor because they are postmenopausal, and then we reassess them after about 18 months. If they are still failing, we might need to now add tamoxifen, which is the one we usually give premenopausal women. And then we're going to follow them up again. But like we said, some patients will respond completely and the cancer is completely gone, but it's not something yet in this day and age that we'll consider for a young, fit patient where we can actually get 100% cure with surgery.
I think we missed you a bit there. We missed certain things. I think I just had a search myself on my side.
Oh, sorry. Yeah.
Just say that again, what you said in terms of, is there any, I'm sorry, I'm going to have to let
No,
you
it's fine.
repeat that, Doc.
That's fine. Yeah, so what I was
Is
saying
there
is,
any, yeah.
Yeah, is there a role for primary hormonal therapy? So like we were saying, if you're a young, fit patient, it's not something we're generally going to consider upfront, because we know that with surgery and chemotherapy and radiation, we can actually get 100% cure. But if you are a patient above the age of 70 who's got an early tumor, something we call a T1, N0, in other words, no spread to the armpit nodes yet, then we can actually do something called primary hormonal therapy. In other words, we're going to give just hormonal therapy. We're going to reassess and see if you're responding. If you're not responding, we opt for a second line, and then we can decide. But that's generally because we're trying to not do surgery for those patients. Ideally, in this day and age, if you've got a young patient, fit patient who's fit for surgery, the curative option is surgery.
Okay. And then, can somebody, the second question that comes now from Fina Kodisan as well, she says, can someone who does not have a medical aid also get reconstructive surgery?
Yes, so definitely. In the government hospitals we've worked at, for example, I've worked with David in many government hospitals. So basically what we do have in government is plastic surgery facilities as well. So definitely it might not happen as soon as if you had a medical aid, and whereas the plastic surgeon is readily available in theatre to reconstruct your breast. What happens in the government setting where you don't have medical aid, you probably will be operated now, you'll go for your chemotherapy, you'll go for your radiotherapy, and later down the line, once your wounds have healed, everything is 100%, we will definitely get a plastic surgeon on board. Again, it needs to be within limits. We won't obviously consult for an above 75-year-old, but definitely a young patient, fit patient who can undergo a second surgical option, for example, flap surgery or implant surgery, we do refer them to plastic surgery with government services.
Okay, yeah. We're talking breast cancer with Dr. Unita Singh, all the way from Centurion Reslow Private Hospital. Listen, we used to think that when you have breast cancer, it equals to losing the breast. But now we know that we've advanced so much that we don't pride ourselves as surgeons by removing the breast. We actually pride ourselves on how much we can save your breast. And then you need to help us that when you have the early disease, when you have a lump, go consult early. Don't wait to go and get other alternative and everything. Look, I'm here to advocate for medical help because I've seen people delay. And if you come through early, you stand a chance where the cancer can be treated quickly and your breast will look the same. We said we've seen so many reconstructions. We have attended so many reconstructions that are happening even in government. So there shouldn't be a fear to say, but if I go to the hospital, they will just remove my breast. There's nothing like that. We don't just remove the breast. Like she said, there's a team we sit with that consists of other people who at the best interest of saving your breast as well. And we can say, no, but don't cut first. You know, knife down, let's do this, cut this only piece. You know, it becomes easier now. And treatment for a breast is tailored with the patient respected. So if you follow the right screening tools, if you worried, you know, come through and you get checked. There we have a doctor who can check. She doesn't say she'll send it to somebody. You can go to her when you're around the area, and then she'll help you with that. Another issue is this. We must walk away from thinking, I'm too young to worry about the cancer. We must understand that we have families who are private or who keeps whatever they're suffering from to themselves, and you won't even know after they pass on, and by that time you don't even have the chance to ask because you know you are mourning. You don't even know what happened to your aunt. You don't know what happened to your uncle, because remember, when you have this BRCA gene, you can have an uncle who has a breast cancer from BRCA gene, who has a prostate cancer, sorry, from BRCA gene, or even breast cancer as well. But if you don't know that the prostate was because of the BRCA gene that you all have, you will then think, no, it's just one of those things, and you keep it. The fact that we don't know much about our family history as we would ought to know, because people keep their health profile secret. When you have something, just consult. So don't wait till it's late. Now tell me, Dr. Singh, I wanted to ask you this question. Does government offer some kind of a screening? Can I go there and present my history? What must I do for me to have my breasts? Well, I mean, as a woman, I mean, I'm not asking my mind, but I mean, as a woman, what does one need to do to get the breast checked? Over to you.
So in South Africa, we don't have a formal breast screening program. Yeah, can you hear me? Yeah, so I was saying in South Africa, we don't have a formal breast screening program.
Go ahead.
But what we do is we sort of take or sort of adopt measures from the UK and the US. And that's where we come with the whole, do you have a family history? Screen earlier than the age of 40. If not, from the age of 40. So yes, if you do have that family history, you need to present to us early. There are multiple breast units that are specialized. For example, in Pretoria, Steve Biko has a specialized breast unit. Kalafong has a specialized breast unit. So if you do have that problem, definitely it's available in government. You come to us, we might not be able to do the genetic testing because that's quite expensive, but we will be able to offer the full screening program that is required. So be that ultrasounds because you're too young or mammograms when you're older, we definitely will offer that. Again, we'll stick you to that full screening program, and then it's your responsibility to keep coming back at those regular intervals. We also offer risk-reducing surgery. So again, maybe you opt to do the genetic testing in private and you show us the results, we can still offer you the same surgery that we would offer the patients in private. So not having a medical aid, you must remember, is not really disadvantageous anymore, because we do have specialized breast units at academic hospitals where we've all worked. That's actually where we've all been trained, where we've got most of our clinical experience from.
Yeah, and that's also true. Now that you're thinking at home, but when we're in government, we wait. Let me tell you, once you present to the right platform and you get to be seen, you won't have to wait when you have a cancer. I can tell you that part, because when we used to be a trainee specialist, we used to make sure that if there's any cancer that is on a list, it doesn't even wait 3 weeks or 2 weeks after getting the results. We call them quickly and we give them preference. There's one thing that you need to understand, is that each time we move forward, we get to know more, and the response becomes quicker. That's why I don't think now people should be worried about the waiting time and everything. You present your GP, they see a lump, I can tell you they will call one of the breast units that she alluded to, that we all were taught under those. We all knew how to operate the breast from those units. And also in Joburg, there is a lot as well. There's Para as well, there's Joburg Gen, Sharp Matreke. We are one team, and I can tell you, if you need help, go and consult, and then once you get referred, we'll teach you as such. Now tell me, is there any other newer treatment modality that are coming through? I'm asking you this question because I know that you just qualified, you fresh from the box, so you know the latest literature. What is the new things that are coming up, or what are promising? Because I know there's some legends that have done some good studies, and good things are coming up right here in South Africa and right here in GP, by the way.
Yeah, so the newer things that are coming up, and actually that will be available probably in state within the next 2 to 4 years, is something we also call Oncotype DX. So that's something where you can test the tumor itself in the biopsy results as well, and sort of see whether this patient long-term has a higher risk that this tumor might come back, firstly, or that it's more aggressive and might need chemotherapy. So now we don't need to actually give everybody chemotherapy anymore. Now we can actually selectively choose the patients who will have a higher risk of recurrence because of a more aggressive tumor. There's sort of like a scoring system that we use on the tumor itself. So that's up and coming. It's already out in a lot of the countries and in the private sector, but I'm sure in the state it will be available soon. The other thing is targeted therapy. Like we said, we know of HER2. There's going to be multiple more molecular targets that are going to be studied, and targeted treatment directly for those biologic markers. So I think that's generally what's going to be up and coming. And that, with all the other cancers, for example, colon, rectum, anal, all of those things, that's the way the world is going, is to more targeted therapy for that specific tumor. And I think, if we stay tuned, probably about 5 years' time down the line, everything will be more towards medical. Already we're moving more towards giving chemotherapy almost to every cancer. We barely operate cancers upfront these days. Even small tumors, generally, because they are so aggressive, we note that the best results are actually with giving chemotherapy upfront, reassessing the patient, and then offering them surgery. In that way, you're actually getting the whole package sorted, because chemotherapy is addressing the system. It is systemic treatment, where surgery only addresses the local problem. Radiation only addresses the local problem.
Oh yes, you heard it. I just told you, we don't pride ourselves anymore by how many breasts we remove. We actually pride ourselves with how many breasts we've saved. And we're actually moving more towards away from the knife. And then, knife becomes something that we do if other things didn't resolve. But at the point, at the level now, or at where we are up to date, we don't just cut each and every tumor. the oncogene DX, it's actually something that is much more promising, that is affording us, a spectrum or dimension that has never been seen before. So I want to thank you, for the opportunity you took and the time you took, even in the presence of this load shedding and the networks going up and down, the time you took. We know that your time is expensive as a surgeon, and congratulations again. You guys are the newest surgeons that came out of the box in the College of Medicine South Africa, and the other ladies that I think it was only ladies in touch that were writing this time, and you guys, just like us, produced 100%. So we thank you. We thank you so much. Your last parting words. Just remind us how we can find you, make an appointment with you, and we thank you that as we open the Women's Month, really, you were the first one to stand up and say, listen, I can educate, listen, I'll spare the time. And we also thank Sauma HD Radio. This is one of the radios that gender-based violence, they're promoting gender-based violence campaigns so that we can prevent the gender-based violence, we can fight against it. They are there. When we try and educate women and celebrate them, they are there. When there's a topic that involves the community, they are there. So that's a very nice platform, for us to discuss this as well. Sauma HD Radio, they are there. So we thank you again for coming through. Where do we find you? And then how do we get to be referred to you so that people can know, can they walk through your office, or they need to see somebody first, or what happens? And then last parting shots, we say good night. Over to you, man.
Thanks, David. Yeah, thank you again for the opportunity. And yeah, I just want to say again to everyone, don't be afraid to seek help. Don't be afraid to come to us. Come to us and let us do our job. Let us help you. And yes, I am based at Raslo Private Hospital, and I actually work with quite a senior breast surgeon. She's highly, highly experienced in breast surgery. It's Dr. Fatima Dokrat, and she runs a breast unit at Raslo Private Hospital as well as Netcare Krugersdorp Hospital. So we'll be gladly willing to assist. If ever you need, you come, you book an appointment with us, we refer you for a mammogram, and we take your treatment plan from there. Thank you.
Thank you so much. Thank you so much. It leaves to me to thank the powers that be, to thank all the platforms. Thank you very much for tuning in on YouTube. Thank you for tuning in on Facebook. Thank you for tuning in on Sauma HD Radio. We'll be back again this Sunday on In His Grace and Mercy Ministries from 7 a.m. till 9 a.m. And on Thursdays, we are always here from 7 p.m. till 8 p.m. Sorry, we couldn't be there last week. I was at some congress. Learning, you never grow old. Learning, we learn every day. But I'm glad I'm back, and we are back and up and running. From the powers that be, from myself and the MK team, I am Dr. Kekana, I am Pastor Kekana. We'll see you again. We'll see you. We love you. We appreciate your support. We also appreciate the fact that you are willing to learn with us. But before I let you go, I just want to say this so that you understand what I love.
In your face, all over the place. We're online 24/7. 24/7. You're listening to the hottest internet station.
Indeed.
In your face, all over the place. We're online 24/7. 24/7. You're listening to the hottest internet station.
Yes, that's from myself and the MK team. Let's close with prayer and then see handle. Lord, thank you very much, God. In a beautiful name, the name of our Lord Jesus Christ, we thank you, God. You're wonderful, God, an amazing God, with a kingdom that is everlasting, the kingdom that does not move. God, we thank you. We thank you. Amen. See you again on Sunday. Thank you very much.